Salam alaikum. Hello and welcome to the Dementia Patients webinar. The time is 3 p.m. here in the UAE and it is the 29th of August 2020. My name is Gerard Moore. I'm the webinar support manager for today. Any questions or queries you can directly send to me. You will see the chat bar on your right-hand side. You can ask questions or any comments regarding today's presentation. If you have any technical issues, you will see a red reconnect button at the top of your screen. You can click that and it will sort out any video or audio issues. If you wish to ask me questions in private to put to Dr. Ahmed, you can click the send to admin only button, which you will see in the chat bar as well, and I will receive those as a private rather than public. This webinar is being recorded and is active for 4 days after the webinar, so please feel free to revisit that at any point during the next 4 days on the link that will be sent to you in an email after the webinar. For now, I would like to hand over to the moderator and the speaker for today, Dr. Ahmed Shatila, consultant neurologist at Sheikh Shakhbout Medical City, with whom this webinar is gratefully supported and endorsed by, and also supported by Lundbeck. We'd like to thank them for their participation in this. Now I'll hand over to Dr. Ahmed to do the lecture, and then we will come back for the questions and answers after that. Dr. Ahmed, the floor is yours.
Thank you, Gerard. First of all, good afternoon, everyone. I'd like to thank the audience for taking time today to participate in this webinar. I'd like to thank SSMC, Sheikh Shakhbout Medical City, for allowing us to have this webinar. And as Gerard said, I'd like to thank our sponsors, Lundbeck Pharmaceuticals, for also sponsoring this webinar. And finally, last but not least, I'd like to thank Gerard for organizing it and taking care of all the logistics. Thank you. So I will be starting right now. Let me see. There we go. It's just loading. There we go. Can you see it?
Yes.
Excellent. So thank you very much. Today I'm going to be talking about overview and updates in dementia as a whole, but particularly Alzheimer dementia. So the objectives of this webinar today is to make people aware of the epidemiology and the pathophysiology of Alzheimer's disease. I'm going to teach people about the clinical modes and presentation of dementia in general. I'm going to talk about updates and diagnostic tests that are available to help diagnose dementia. And finally, we're going to talk about different diagnosis and treatment options that are available. So in this first slide, this slide emphasizes the topic of Anastognosia, or it's the ability or inability to recognize one's own illness or lack of insight into your own illness. And this is something I routinely see among patients and sometimes even family members, that they don't notice or they don't pick up the early signs of dementia. So let me just, is there any way? Okay, so in this slide right here, this is Dr. Alzheimer's, and this is the first patient, Miss Auguste Detter, who he described symptoms of dementia in a patient who was actually in an insane asylum. And on autopsy, he described what would later be known as neurofibrillary tangles and beta amyloid plaques. So overview and practical essentials. Alzheimer's disease is a neurodegenerative disorder, which is marked by cognitive and behavioral impairment. And here's the key word: that significantly interferes with social and occupational function. What does that mean? It has to, in order to be diagnosed with dementia, it has to interfere with your life. It has to actually cause a decrement or deterioration in a previously normal level of function. Meaning, if you forget your keys in your car, that isn't always dementia, you know what I mean? A lot of people come to me and say, I forgot my keys in the car, or I forgot, an appointment. Do I have dementia? And most of the time the answer is no. There's other causes. It is an incurable disease, and there's a long preclinical period, and it's a progressive course. This is a disease, dementia, and specifically Alzheimer's dementia. It doesn't happen over days and weeks. It happens over years and decades, and you get a slow progression of your symptoms. And this is because of plaques, beta amyloid plaques that develop in the hippocampus. These are structures deep in the medial portion of your temporal lobe that is involved in memory and making decisions. Now, whether the plaques themselves cause Alzheimer or they're a result of some other etiology, we're not 100% sure, but we do know that plaques and neurofibrillary tangles do develop. And the cardinal neuroimaging features of Alzheimer's disease is that you get atrophy of the hippocampal regions. So what's the prevalence of dementia in the Arab world? Unfortunately, we don't really have a lot of good studies on dementia in the Arab world. And one way we can look at this is when we do a PubMed search. So PubMed is a catalog of a majority of scientific journals. And if you were to go to PubMed and you put in certain filters on dementia in the world, you could get a hit of like 9,786 articles. Now, if you put the filters and you say, I just want to know about dementia or Alzheimer's among the Arab countries, you go down from 9,786 to only 25 articles. And out of those 25, only 7 of them are epidemiological studies. So we have a lot to learn, and we have a long ways to go. And that's part of the reason why these webinars, we do this, is because it's to educate and raise awareness of medical illnesses, medical/neurologic illnesses to the public. When you look at the cost or the prevalence of dementia among Arab countries, you can see that there's a significant difference between Egypt on the bottom and other countries such as UAE and Bahrain. And the question, sometimes people may ask us, is it because, they're more prevalent, or we're just not diagnosing it? Or that, and I think honestly, it's that we're not diagnosing it, we're not picking it up. And that's why even Egypt, that may have a lot, it's still probably underdiagnosed as well. The cost of dementia. It's a prohibitively expensive illness. And what does that mean? When you look at dementia, you have the direct costs and then the indirect costs. The direct cost could be the person who suffers from dementia. They may lose their job. They're not working or functioning at the same level that they were prior. The indirect cost is family members may need to take time off work. You need to now buy medical equipment, either a medical bed, a bedside commode. You may even need to person may even take time off their own job to care for their family members. So it is an expensive disease, and it's not just a disease that affects the person, it affects the entire family. And in this study right here, when you look at the cost of dementia in our world, it's around $6,700 million, or $6,700 million. The worldwide cost of dementia is more like $6 trillion, which is more than the GDP of Saudi Arabia. Hence, going back to how expensive this illness can be. How present is it? How present is it? Now, for this study here, this was looking at people in the United States, but and overall, when they looked at people with dementia in chronic care facilities, 50% of the people in chronic care long-term facilities had signs of dementia. When you look at people 85 years or older in the general population, it's around 20 to 40% of people above 85 in the gen pop have dementia. Now, when you look at it even more narrowly, greater than 85 who come see a physician in clinic, it's only 15 to 20%. So the way I look at this slide or understand is that 15 to 20% of people who have dementia are following up with physicians or maybe seeing a physician. But 20 to 40% of them are walking on the streets, and they may not have signs, or they do have signs, but they're not aware of their illness. And that's where we need to try to identify these people and help them earlier. Now, when we look at dementia, Alzheimer's is a part of dementia, but not all dementias are Alzheimer's disease. So what does that mean? When we look at this pie chart right here, more than half of all dementia cases are due to Alzheimer's, but then that doesn't mean it's only Alzheimer's. There are other causes of dementia. It can be what we call Lewy body dementia, certain mixed type dementias, which is a result of more than one illness, vascular dementia, as a result of having strokes or chronic strokes over a period of time that just eat away at your brain and cause you to lose memory. And then there are reversible causes of dementia. So basically, not all dementia are Alzheimer's, but all Alzheimer's are dementia. Does that make, hopefully that is better clarified. So when we look at the baseline or the pathophysiology of dementia, now, or Alzheimer in particular, and what's happening is that you have an accumulation of what we call plaques and tangles. The plaques are made up of a protein called beta amyloid protein, and the tangles are made up of a protein called tau. You have destruction of microtubules, which are kind of the structural support of your neurons. They're also used as the highway. Neurochemicals are sent down microtubules from potentially from your brain down to your leg or down to your arm. They can be extremely long, these axons, and the microtubules give structure to these neurons. And you have accumulation of tau, which causes destruction of microtubules, which lead to these tangles in your brain. Now, the thing is, beta amyloid plaques and tangles are present in normal brains, but they're they're significantly higher in people who suffer from Alzheimer's dementia. And if you look at this slide right here, this is a normal looking brain, and this is a brain of someone who suffers from Alzheimer's. And what you notice, there is atrophy. Atrophy is prominent or can be seen by the widening of the sulci. Right here, you can see how it's a little bit more prominent. This area here, this separates the temporal lobe from your frontal lobe. It's called your Sylvian fissure. You don't see that amount of atrophy in a normal brain. Next. Dementia or Alzheimer's dementia is not a disease that happens overnight. It takes years and decades for these amyloid proteins and these neurofibrillary tangles to actually reach a critical point where actually people with Alzheimer's will start noticing symptoms. And these deposition or accumulation of plaques and tangles can happen decades earlier. You may start seeing an accumulation in your 30s, but you may not have noticed signs of dementia up until your late 60s or even 70s. So that's why there is an accumulation of these plaques and tangles that cause neuronal destruction, but it's only evident once you've reached what I call a critical mass. Once you have enough neurons destroyed, that's where the symptoms start developing. And there are certain risk factors that increase your risk of Alzheimer's dementia. Now, women are at a higher risk than men. Severe head injuries, so any jobs or any activities that pose repetitive trauma to the skull or the brain increases your risk of having neuronal destruction and possibly Alzheimer's disease. Altered cerebral perfusion, meaning that you have decrease or narrowing in blood vessels that supply your brain, and that can cause anoxia, and it basically starves your brain of oxygen, which can cause dementia. There are certain genes, genotypes and genes that have been associated with dementia. One of them is the ApoE4 gene, which poses a higher risk for people who have it. Environmental toxins, we're not sure about that, but it's the theory. And finally, as I said, there are certain genes that increase your risk of developing Alzheimer's disease. So when we look at the genetics in particular, or the genes, there are two types of dementia or Alzheimer's dementia. You have the familial early onset, which can be caused by a genetic mutation of the APP gene, the amyloid precursor protein, presenilin 1 and presenilin 2. Now, the presenilin 1 and presenilin 2 are present on chromosome 21. And one of the risk factors of developing early onset dementia are actually people who have Down syndrome. They have 3 copies of chromosome 21, and as a result, they actually, unfortunately, people with Down syndromes are more prone to developing early onset dementia. And then you have the late onset, where the genetic factors are not present, but and these are usually late onset, over the age of 65. This is probably a combination, as I discussed. There may be genetics, we don't know all the causes. There may be environmental, and there is a confirmed risk factor of the ApoE4 gene that may increase your risk of dementia. But again, it's not standard, meaning that, or it's not definite. If you have this defect in this gene, doesn't mean you're gonna get dementia, but you may have a higher risk. Biomarkers. Now, biomarkers are extremely important in any medical illness, specifically, and neurologic illnesses are no different. Now, why are biomarkers important? Because they could enable more accurate and early diagnosis. As I mentioned, this is a disease that happens over decades, and a lot of time there's a very long preclinical phase where people may be prone or they're going to develop Alzheimer, but they have not yet shown symptoms. And if we could come up with a biomarker that actually shows that the person who has this biomarker actually shows signs of dementia, this could help us start treatment earlier, find treatments that actually may change the course of the disease, and we can use biomarkers in a way to develop endpoints or determine a response to treatments. One biomarker that has been shown to be elevated is the CSF, cerebrospinal fluid levels of tau protein. As I mentioned, you have an accumulation of tau, which causes destruction of the microtubules in Alzheimer's disease. And one study has shown that people with Alzheimer's disease, or even early onset Alzheimer's, will have an elevated level of CSF tau proteins, which suggests that they're having neuronal destruction, but they may not have symptoms. Imaging is another way in which we can use to help identify people with dementia. Now, why is imaging important? First of all, you want to rule out any other causes of dementia. So by doing an MRI or a CT, you can look for other abnormalities such as strokes that may be increasing your risk for memory loss or memory impairment, but that's not Alzheimer's. You may find a small hemorrhage, subdurals. You may find a mass lesion or a tumor. All of these may cause memory loss or dementia, but it's not Alzheimer's. And the reason why that's important is because their treatments are different. You would treat someone who has strokes, multi-infarct strokes causing dementia, or a brain tumor causing memory loss, or a subdural hemorrhage. The treatments for those are not the same as people with Alzheimer's disease. People who suffer with Alzheimer's usually have significant atrophy of the areas of the brain known as the entorhinal cortex and the hippocampus. And those are areas involved in memory function, memory storage. So you need your hippocampus to form new memories, but also to retrieve the older memories that's already ingrained or stored in your brain. And what we see in people with Alzheimer's dementia is there's a significant amount of atrophy in the medial temporal lobe and superior parietal. The parietal lobe is actually involved more in putting the world around us into perspective. So you need your temporal lobe to remember things. You need your parietal lobe to be able to put the world that's around you into perspective. In this slide right here, we can see it's a cartoon slide, but what we notice is in this slide you see what we're taking cuts of a brain from front to back. And what you notice right here is this is your entorhinal cortex. This structure right here is your hippocampus, and here are your ventricles. This isn't a normal appearing brain. In a person who suffers from dementia, you see there's widening or enlargement of the ventricles, and you have significant atrophy of your hippocampus. Now the ventricles enlarge because the brain around it has been destroyed, so they just expand to take up the place of the brain that's already been destroyed. PET scans is another way to look at people. PET scans is more now. CT scans and MRI scans look more at the structure of the brain. PET scans look at more of the function or the function of metabolites in the brain. How is your brain performing? Now, in this PET scan here, if you use an amyloid marker and someone who's normal, who does not have dementia, you'll notice blue means that there's not a lot. You have a reduced level of amyloid in the brain, which is normal. You don't want an amyloid in your brain. Now, if you look at someone right here who appears cognitively normal, but this person would develop Alzheimer's 3 years later, what you notice is you're now having a significant increase in red. Red is the deposition of amyloid in this brain. The thing is, this person, while he's normal, he already has, well, he's normal cognitively, he's already showing signs of deposition of amyloid. And this right here is a person who has Alzheimer's dementia. The scans look almost similar, almost identical, but yet this person here has no symptoms. This person here has dementia. And that's where we would like, as physicians, to try to catch people earlier on so that we can either treat them or enroll them in clinical trials so that we can determine if any medications can slow down or even improve their quality of life. What are the criteria for diagnosing dementia? Dementia, as I said, it's a cognitive decline that interferes with ability and function at work or your usual activities. It has to be a decline from your previous level of functioning. What does that mean? I mean, right now, I can't code computers. I'm not a computer genius. So if I go to my doctor and says, Doc, I can't code my computer. Well, the answer is, well, I could never code my computer. So that's not dementia. It has to be a significant deterioration from a baseline level function. If you couldn't do this job before and you can't do it now, that doesn't mean you have dementia. You also need to rule out any psychiatric disorders or any other medical disorders that may cause you to have memory loss or impairments. And you have to have two cognitive domains that are involved. So in summary, you have to have a deterioration from a previous normal level of functioning, and you have to have two regions or two cognitive domains that are involved. What does that mean? You got to have memory, reasoning and judgment, physiospatial, language, or personality. If you have those two with deterioration, then you meet criteria for diagnosis of dementia. Now, how do I approach people who come to me in clinic with the idea that they're forgetting things, or family notices that their loved ones are forgetting things more often? First of all, the most important thing is the history and physical. You want to get the history because, as I mentioned, Alzheimer's disease is not a disease that happens over days and weeks. It happens over years and decades. So in reality, when you ask, you want to make sure it's something, how I usually say, when you ask or you look at your loved one or someone you know with dementia, it's not like yesterday was good and today is bad. It's more like today they're at a certain point. 6 months ago, they were better. 6 years ago, they were even better than that. It's a slowly progressive disease. The neurologic exam should be normal. I should not find any focal abnormalities or focal issues. Blood tests, labs should be normal as well, meaning that there should not be another cause for memory loss. Neuropsychiatric test is important because it can help you determine what baseline level of functioning this person has, and if they have a detriment or there is already deterioration, we can pick it up. And then, as I said, imaging and biomarkers are important because at this point you're looking for other causes to rule out, because before I say someone has Alzheimer's dementia, I want to make sure that there's nothing else that may be causing it. Lead symptoms of dementia. As I said, this is impaired. People with dementia have an impaired recent memory, and it's slowly progressive. They may, at the end stages, have what we call behavioral changes. They may start getting paranoid. It's not uncommon sometimes family members will say, my loved one has dementia, or the person I care for has dementia, and they're starting to get a little bit paranoid, meaning they think family members are starting to steal them, or that the government's spying on them, or that people want to rob their house. And it can start affecting language, speech. They can sometimes have confusional states. They're better at certain points in times. They're worsening at night. But overall, there's still a progression from baseline, and they may have previous strokes. Now, other causes of rapidly progressing, as I mentioned, you can have frontotemporal, semantic frontotemporal, Lewy body dementia, vascular dementia. All of these are still dementias, but the difference is the timeline. How do they present? Because, as I mentioned, Alzheimer's disease is not a disease that happens overnight. It's slowly progressive over years and decades. We want to rule out any reversible causes of dementia. Reversible means that people may have delirium. Delirium is basically a fluctuation of memory due to another medical illness. It's not uncommon that we sometimes see people elderly patients who are in the hospital, and they may have a UTI or they have pneumonia, and they're a little bit more confused. That's not dementia. That's usually a result of them being sick in the hospital. Once the primary factor is resolved, they tend to go back to their normal level of functioning. Depression is routinely can cause memory impairment, but again, it's not dementia. As I mentioned, subdural hematomas or normal pressure hydrocephalus can cause memory impairment and can appear like dementia, but it's a different cause. Tumor space occupying, vitamin deficiencies, thyroid dysfunction, seizures, drugs, alcohol, medications. And then, as we said, there's infectious disease such as syphilis and HIV that may cause dementia or reversible cognitive disorders. What are things you need to do to exclude Alzheimer's? As I mentioned, it's not sudden. This is a slowly progressive disorder. You don't see people with Alzheimer's with gait abnormalities early on. This tends to happen more at the end stage. They should not have a focal neurologic deficit, meaning when I examine people with dementia, or with Alzheimer's dementia, they should have a relatively normal exam. The hallucinations, as I said, it can present, but it presents more at the end of dementia, end stage, not early on. Cognitive fluctuation, again, if it gets better and worse throughout the day or only worse at night, that may be due to something else. They may be delirious. Depression, you got to rule that out. And I said you got to rule out any toxic metabolic. And your MRI has to be not suggestive of any vascular or infectious insults. What are some risk factors for developing Alzheimer's? As I said, advancing age. We see it more in elderly patients, but that doesn't mean that it can't happen earlier. Family history is a risk factor. Having the ApoE4 genotype is a risk factor. Obesity, insulin resistance. You got the vascular risk factors such as hypertension, hyperlipidemia. They don't, now each one of these in and of itself don't cause dementia, but these are risk factors, meaning that we may be able to, if you better manage your other comorbid conditions, you may be able to at least decrease your risk of developing Alzheimer's dementia. Traumatic brain injury, as I've mentioned, Down syndrome is a risk factor, and inflammatory markers. And again, each one of, and the important thing here is that while each one of them is a risk factor, being elderly or being over 95 doesn't mean you're going to get dementia. And, but at the same time, you're more likely to have dementia if you're older, more than 85 or more than 65. When we look at this graph right here, you see two curves. You got the red one, and you've got this, I don't know, like green, mustard color. And what we see is we have the asymptomatic phase, you have your pre-dementia phase, and this is the dementia phase. And as we said, even though you could be in your asymptomatic or your pre-dementia phase, you're already having accumulation of beta amyloid. And by the time you've reached critical threshold, that's when actually you may know signs of symptoms. While a person without it, they can go into advanced age, old age, and they could be still completely normal and completely productive. Preclinical Alzheimer's. A person with preclinical Alzheimer's may appear completely normal on physical examination and mental status, but there's already specific regions of the brain, such as your hippocampus and entorhinal cortex, that's already affected. In mild Alzheimer's disease, they're already starting to have mild memory loss. They may start getting confusion about location of familiar places. And what does that mean? They may forget how to get home from their job. They may get lost easily. And this is important. With someone with dementia or Alzheimer's, they may appear what we call normal. But the thing is, if they're driving on the road and there's a traffic detour, they may get lost. They may already start having trouble handling money or paying their bills on time. And they can have compromised judgment that leads to bad decisions. Now, again, you can get loss of spontaneity and you can have some mood and personality changes as well. Once you go from mild to moderate, the symptoms start becoming more prominent. Now the memory is more impaired. The attention span is now shortened. They're not focusing as much. This is where people start having problems recognizing friends or family members. it's not uncommon. They'll ask you who you are, what's your name? Oh, I'm Ahmed, I'm Ahmed. And then be like, oh, okay, yeah, you're Ahmed. And then maybe like the next day, who are you again? What do you do? They may confuse you. They're now starting to have problems with language and reading, writing, and calculating numbers. And they have difficulty organizing thoughts and thinking logically. Once we go in moderate Alzheimer exam, this is where I said repetitive statements or movements. They may start having hallucinations or delusions. This is where they start. Family members may say, "Oh, my loved one, he's starting to get a little bit more paranoid. He's starting to think people are spying on him." It's not uncommon sometimes that family members may say, "Oh, he's starting to talk to dead people," or he's hallucinating, seeing people that aren't in the room and having conversations with them. This is something you need to keep in mind. And the thing about dementia that probably hurts family members the most is that the patient or the person may start telling their loved ones, "Oh, you're not my kid. I never loved you. I wish I never had you." And this is the psychological impact on family members. And I always have to remind people that it's not the person talking, it's the disease talking. So just because the person tells you, "Oh, I don't love you," or "I wish I never had you," that most of they probably don't mean it. But you have to remind family members that this is not the person, it's the disease. And when you go into finally the final stages or severe Alzheimer, this is where most people now say, okay, there's something wrong. He's no longer talking as well. He's now dependent on his family for all his activities of daily living. He may not be eating. He may not have no conversation. There's already loss of bladder and bowel. And this, unfortunately, is something that I routinely see in clinic. I would like to see people more in the early stages because, again, we do have treatments that are available that can slow down the progression of dementia. Once you reach severe end-stage dementia, there's not a lot of things we can do to help. It's more symptomatic at that point. And I always give the example of, your house is burning down. If someone's house is on fire, you call the fire department when it's early, not at the very end when the house is already on the ground and in ashes. There's nothing they can do for you. As we said, the life courses. This is a disease that happens early, that starts off earlier until the symptoms become manifest each other. And again, we've got the risk factors that I've mentioned: obesity, hypertension, hyperlipidemia, and then strokes. All of these will cause brain injury or brain damage. And the thing is, these people are still functioning relatively normal because we have brain reserves. Once the brain reserve has been lost, or there's no longer ability for the people with dementia to actually compensate, now we start seeing symptoms of what I've discussed. Neuropsych testing, there are a lot of types of neuropsychological testing. I'm not going to go in detail of each one, but what I like to do normally is someone who does suffer from dementia is they get a formal neuropsychiatric exam because it gives me a baseline of how they're functioning. And this baseline may be important for first to determine, maybe they can't, if there's already significant detriment in their cognitive function, this may at least help the family know that their loved ones should not be functioning, should not be driving cars. Maybe, I'm sorry. It's the sneeze that didn't happen. They may not be able to drive a car. They may not be able to handle their bank accounts. And these are important things. One thing that we can do in clinic is do a MiniMental status exam. Now, the MiniMental status is not just because you have an abnormality in the MMSE or MiniMental status exam, doesn't mean you have dementia, but it may point to that you're having difficulty with function or memory. Now, it's based on certain questions, simple questions: age, date of birth, serial 7 repetition, spell the word forward, spell it backwards, location, drawing 2 intersecting pentagons. Now, you got to keep in mind that this is very culturally dependent or even education dependent. And what do I mean by this? Now, it's not uncommon sometimes that, I'll get patients, if they may not have went to school, or maybe they didn't complete high school, so their spelling may not be good, or maybe they're not good at math, but, so they may have difficulty, but that doesn't mean they have dementia, so you have to keep it in mind. The example of what I sometimes use is I one time had a patient come to my office. He did horrible on the MiniMental status exam, but yet he could tell me the name of every camel that was in the race and who won the race and what's the next race, when's it going to happen, and what are the previous races. So even though he scored really bad on the MMSE, he knew current affairs and past affairs, and he was up to date. So he probably didn't have dementia. But another thing is, another way I sometimes ask is I'll ask my patients, who's the leader of the UAE? Who's the current ruler? And sometimes, and you'd be surprised that these are people that look relatively normal. They don't have memory loss, but they're already confusing things that most people who were born and lived in the UAE their entire life, they should be able to answer and tell me who Sheikh Zayed is, and they really wouldn't be able to, or they'll tell me that he's still alive and he's the current leader. And that's where even families start getting surprised, because they're like, wait, no, that's not right. But it can be subtle. That's the important thing. That, and this person, even though he appears to be normal, there's already some fluctuation, there's already a detriment in their memory. The blood test, as I've mentioned, what we do, they exclude dementia. CBC, we'll look at inflammatory markers, we'll check basic chemistry, blood work, liver function. I may consider HIV or syphilis testing, and then thyroid and vitamin function as well. In this graph right here, or this curve right here, we see the progression of treatments. We do have treatments for dementia that have been shown to slow down, and they do not stop, they do not reverse, they do not improve what's already lost, but they have been shown to actually slow down, whether it's memantine, or which can work on glutamate, or acetylcholinesterase inhibitors. They have been shown to help slow down the progression of dementia. When we look at the 100-year history of dementia, in the 50s, we used to think it was just presenile dementia. We thought it was probably normal, and we used to say, oh, it's just advanced age and it's expected. But then we realized, no, that's not true. And in the 70s, we started developing hypotheses that there are different neurochemicals, neurotransmitters that may play a role in people who develop dementia. And as a result, treatments have been aimed at trying to slow down or affect those neurotransmitters. In the 90s, 2000, we started getting into the age of genetics, where we started realizing that there are certain genes that increase your risk of developing dementia. Also, certain medications were improved. Glutamate was recognized as a role or playing a role in dementia, and that's where memantine was approved, which is used to treat moderate to severe dementia. So what are some myths about Alzheimer's? First of all, Alzheimer's is not part of normal aging. Just because you are at an advanced age doesn't mean that Alzheimer's is normal or expected. I've had people that are well into the 95s and they are still functioning, living independent, and they have no issues. Aluminum pots and pans can cause Alzheimer's. No, that's not true. Aspartame does not cause Alzheimer's. Vaccines and flu shots do not increase your risk of Alzheimer's. And patients who had a family member with Alzheimer's, that doesn't mean that you're going to have it as well. Now, here are my references, just if anyone's interested in going back and looking at references. And finally, thank you. Now, one thing I mentioned, I said the Anastognosia of people to recognize that there is a problem. Unfortunately, it's not uncommon for me in clinic to see family members bring their loved ones or bring their parents when the patient is already in a diaper or in a wheelchair. And when I talk to the family members and I ask them, so when did this occur? They're like, oh, he was fine up till last week. But you realize when talking, this is not a case that appeared to occur last week or even last month. So then where was the problem? And I think the problem is it's not so much a problem, but it's how it's part of our culture. And what do I mean by that? In our normal Eastern culture, when someone, give me an example. When we graduate, what's the first thing we do? You tell your parents, Mom, you don't need to work as hard. Dad, you don't need to take care of the bills. I'll take care of it. You don't need to cook. We got it. You don't need to go to work or pay your bills. We'll take care of it. So this person that was normally functioning at a high level of function is now doing less because us as children, we're doing everything or we're minimizing the amount of work they need to do. So these people are now sitting at home and they're not really expanding, or they're not utilizing their brain the way they should. And so hence you don't see the more milder symptoms. And it's not until the very end, when people now start forgetting family members or start hallucinating, they're like, oh wait, there's a problem. But that problem didn't happen now. It happened earlier, but we just weren't letting our family members do what they need to do. And I think that's why it's important. And I always tell patients and family members, you want to stay as active and as involved for as long as possible. It's not that, just because you've reached 65, you shouldn't stop working. No, you should be productive for as long as possible and utilize your brain. Pick up hobbies, do crossword puzzles, and stay at work for as long as you can. And that's it. Thank you very much.
Thank you, Dr. Ahmed, for a very nice, informative and educational presentation. As you would expect, there's been a lot of questions both on the public chat bar and also the private messages that we have noted here as well. Please, if you are watching, please do feel free to type any messages or questions or comments for Dr. Ahmed to answer now. I do have a list of questions that have already been sent through. One question, you touched on it, Dr. Ahmed, with regards to if dementia is hereditary, if it's a family issue or not. One person saying, oh, my father has it, I'm concerned that is there a high chance of me now getting dementia as a result?
Well, thank you, Jared, for the question. First of all, as I mentioned, there is not one thing that causes dementia. I've listed multiple risk factors: diabetes, hypertension, obesity. There are certain things that we can change as people. Those are the modifiable risk factors. And there's certain things we can't change. We can't change who our parents are, and we can't change our genes or genetics. So just because just because you have a family member with dementia doesn't mean you're going to get it. But at the same time, I would say you should look at the risk factors that you have and try to treat them or modify them.
Okay. Thank you. Is there any way to, outside of medications, is there any way to delay the progress of dementia? What do you see in your clinic? What do you advise to patients in your clinic to help them slow down the pace of dementia?
Well, one thing is, like I said, one thing we can use to slow down is look at the risk factors. Again, we know that there are certain risk factors that increase the probability of someone developing dementia. Repetitive head trauma, diabetes, hypertension, obesity. These are things that we can do to reduce risk factors. Also, people who are mentally engaged have a lower risk. I'm not saying it's zero, but your risk of developing dementia is lower for people that use their brain and maintain the ability to use their brain for longer periods of time. So reading, staying educated, staying mentally active are all important things.
Okay. A question here is, what is the typical normal age that symptoms of dementia start showing amongst the population here?
As I've said, the symptoms, usually we may see symptoms in the 60s, early 70s, but that doesn't mean just because you're 60 doesn't mean you're going to get dementia. And just because you're 90 doesn't mean that you're going to have it. Like I've said, my grandfather, he's 95 years old and he still lives by himself and he makes kites. So being old doesn't mean that you're going to have dementia, but being young doesn't also exclude that risk as well.
I see. What a question here asking about specific foods to eat. Do you know any clinical data about certain diets or foods which help manage dementia better than others?
Honestly, I don't think there's a specific food or meal that will minimize your risk of dementia, but certain foods increase your risk for other illnesses. We do know that eating a lot of sweets increase your risk of diabetes. Fried food, fatty foods make you more likely to be obese or have hypertension, which again may increase your risk of dementia. So while there's no food that doesn't prevent it, the foods we eat do increase our risk for developing it.
Okay, thank you. A question on the private messages, I believe it's come from a healthcare professional. They're asking if a patient had a TIA or stroke, would that raise my suspicions towards vascular dementia, even if they have Alzheimer's disease signs or symptoms, or could it be a mixture of both?
That's an excellent question. As we said, having strokes or lacunes increase your risk of what we call multi-infarct dementia. So, because at the end of the day, every time you have a stroke, you're losing billions and billions of neurons. So you may not notice any problem now, but eventually, if you keep having strokes and you're losing neurons, you're going to start having problems with memory or functioning. Now, can you have multi-infarct dementia and Alzheimer's? Yeah, it would be considered a mixed type dementia. But I would first focus on the multi-infarct dementia and reducing those risk factors. Taking aspirin, making sure your diabetes is under control, your hypertension is under control, your hyperlipidemia, don't smoke. So I would look at those risk factors and I would manage them.
Okay, thank you. A question again on the private messages, I believe from a caregiver. There's a treating the father at home. Is it worthwhile to engage the help of an occupational therapist as he advances through and progresses dementia? What do you advise in that scenario?
I think, the way I look at it is it's important to stay as active as you can for as long as possible. Even though there may be memory loss, you still want your loved one to be active, try to keep moving their limbs, because you don't want them to start developing contractures or difficulty ambulation or even at risk of falling. So it is important to get evaluated by a physiatrist, a physical or occupational therapist, because again, they may also pick up risks or risk factors. They're prone to falls or injuring themselves, and they may need a special medical bed, or you may need a sitter. So it's important to have a physiatrist, a rehab specialist address or assess your loved one.
Great, thank you very much. Quite a lot of questions coming from, I think, both caregivers and healthcare professionals saying, what are the best ways to communicate to people of dementia? What are specific words to use, actions to do? How do you speak so that the message can be communicated as clearly as possible to the people of dementia?
I mean, first of all, I think that, that's a very good question, and sometimes it's hard because you're kind of treading on ice or on thin ice on this one, because you want your loved one to know that they have dementia, but at the same time you got to understand that how do they process that information? And what I usually tell family members is don't fight them per se. Sometimes your loved one will be like, I want to go home, or I want to go. It's not uncommon. I get a lot of patients who are originally from Yemen, and they'll be like, I want to go back to Yemen. I want to see my kids. And they start fighting with their other children because the other children says, no, you can't go. We're going to have, multiple reasons why you can't go. And they end up fighting with their family member. And I'm like, look at it other way. Say, like, if they're forgetting, because they'll be repeating the question over and over, don't oppose them or don't fight with them, because they may not remember, the next day what you were even fighting about, but you're going to be suffering. So it's a hard question, but everyone's different.
Okay, thank you. A question coming on, is there any link from dementia with regards to chronic sleep deprivation or vitamin D deficiency? This is one question. Do any of those two lead, or seen data lead to dementia?
Well, we know that sleep apnea increases your risk of hypertension, increases your risk of strokes. So having sleep apnea or the inability to sleep can increase your risk of dementia. There are certain medical conditions, extremely rare, called fatal familial insomnia. This is extremely rare. It's genetic, and people who have it, I have the inability to sleep, and as a result, they become psychotic and have dementia. But so sleep is important. You need to sleep. Try not sleeping for 24 hours, and you're going to notice that you're a little confused and can't function. So sleep is important.
Thank you. What is the life expectancy of a person once diagnosed with Alzheimer's?
That's a little hard, because it all depends on, again, dementia is a disorder of the brain. Now, if you are, as long as they may start, it depends on how they're being cared for per se. As long as you're taking care of their feeding, their hygiene, there are other medical illnesses, they may live longer than someone who is not getting adequately treated. So it's a little bit hard to say what your life expectancy is going to be like because you have dementia.
Okay, thank you. Are there any common brainstorming activities or mental games which you advise your patients to perform to help slow down dementia?
I honestly say be as active physically and mentally as much as possible. You know, it's not about playing Sudoku or crossword puzzles. It's you want to be as engaged, as entertained, not even when you're young, but as we grow older. You want to, that's why I say it's important to stay mentally engaged in activities. Pick up a hobby. You know, I know us in our culture, we like to, as we get older, we want our parents to do less because we think we're helping them out. But in reality, let them stay as active and mentally and physically as they can so they can enter old age more gracefully. It's not a bad thing.
Thank you. Another question coming in with regards to people with dementia when they become agitated and restless and perhaps aggressive. How do you help pacify them, calm them down? Are there any methods that the caregivers or healthcare professionals watching could use to help in such scenarios?
Well, thank you for the question. There are two ways you can do this. I think sometimes first of all, what you don't want to do is you don't want to restrain the person. You don't want to physically tie them to the bed because that just makes them more agitated and more confused because they don't know why they're being restrained. You know, sometimes it could, you know, sometimes some family members will just by being present in the room and just reminding them, you know, you shouldn't do this, mom, or it's all right, nothing's wrong. That'll calm them down. Now, but again, that can be hard because, you know, at the end of the day, it's physically, emotionally taxing on the family members. But if that's possible, that we sometimes recommend that. Having a caregiver can also help. There are medications that can be used that can help calm people down, and so they're not as aggressive, they're not hallucinating as much. Because as I said, it's sometimes really hard on family because you're hearing your what looks like a normal person tell you, you're not my child, I don't love you anymore, or you know, you were my biggest mistake. And you got to remember that's not them talking, but it still affects the family members.
Exactly, thank you. Question coming as is there a test to perform that they can perform to differentiate between memory loss of dementia or memory loss from depression?
Yeah, well, you know, first of all, as I said, you know, in order to have memory loss from depression, you got to have signs of depression. And depression is usually you are feeling sad or in a depressed mood for more than 2 weeks. You are starting the things that make you happy are no longer making you happy. You may have homicidal or suicidal ideation, meaning you want to hurt yourself or hurt someone else. You're withdrawn. So if you don't have those symptoms of depression, it's usually not depression from memory loss from depression. So it's important. That's why we always ask people who show signs of memory loss, are they depressed? And you start asking questions about depression. And if you don't have it, you're probably not depressed.
I see. A private question coming in. When is the correct or the appropriate time to advise people with dementia to start medicating? Is there a threshold, or are there certain symptoms that have to be checked before medications are started to be given, or can they go on it from early?
Honestly, they should. There's the thing, the medications, and we didn't go into medication because that's not the purpose specifically of the lecture. But medications have been shown to slow down, maintain independent living, so keep people with dementia as independent for as long as possible. So again, you know, if they're already showing signs of symptoms of dementia, the medication will help them at least improve their memory. You know, they may still regress or deteriorate, but it's at a slower pace. And you know, they're able to be as active as possible for as long as possible. So I usually start if once they're diagnosed, I will start treatment.
Okay, thank you. Is there any relationship between personality traits and dementia?
Not that I know of.
Um, Is there? Do you know of any? We're going about medications, but some people are asking do you know in the pipeline is there any new advanced drugs which show promise that are coming out soon, or are you not aware of anything?
Specific names not aware, but I know that they were looking at monoclonal antibodies against amyloid. Now, I don't know what the results. There was one result that initially it didn't show a significant improvement, but I think when they looked at the study again at different parameters, it may have been more beneficial. But again, I can't comment.
Okay. What do you know of the role of vitamin E in helping to stabilize or slow down dementia?
Vitamin E it's one of those vitamins that has an antioxidant role. Nothing. I can't comment that I would say that this is going to help or would hurt.
When is there ever cases to involve psychiatric managements or assessments when dealing with people of dementia, and when would you advise people to go down that route?
I think, again, people with dementia may have depression, because again, especially early on, they may notice people with dementia that I'm starting to forget things. I can't do the things that I normally can do, and that can make them depressed. And I think psychiatry early on is important because even if though they have Alzheimer's, they may be feeling depressed. And for end stage dementia, when they're hallucinating, again, psychiatry is definitely important because there are medications that can be used to reduce the hallucinations, but you also want the expert because they have side effects. So I think having a psychiatrist involved early on in care is important for people with dementia.
Thank you. A question here, I believe from a caregiver. When my father was diagnosed with dementia, it was associated with temporary visual disturbances. Can you give any further explanation as to why this happened?
The visual disturbances, I think what I understand from the question could be the hallucination. I sometimes see patients with dementia, family would be like, oh, they're talking to dead people or they're imagining their loved ones and they're having conversations. So if that's what you mean by temporary visual disturbances, then we do see it. But I'm not quite sure what else that question's entailing.
Yes, that's all the information that was provided. If the person can elaborate more, we will go back to that question again. Question from a healthcare professional in terms a patient that has frontal lobe atrophy. How can we keep him engaged and reduce his anxiety?
So frontal temporal dementia or frontal lobe, that's a type of dementia. It's not Alzheimer's, but it can present with dementia, or it can be type where that's more of loss of inhibition. They may, but not memory. Now, again, you got to keep them engaged, but different ways. I think that's why people with dementia, it's a multifaceted approach. It's not just seeing the neurologist or the primary care doctor. You have to have psychiatry, rehab, neurology, internal medicine all involved to help try to keep these patients as active as possible, minimize other risk factors, and take care of any problems that develop.
Okay. Are there any side effects that people experience when on medications in dementia?
Depending on the medicine we're using, but most of the medications that we can use or treat people with dementia, they have minimal side effects. I mean, again, it's always risk and balance. It's the balance between risks and benefit. But overall, the risks appear to be low. The benefits of the medication outweigh the risk, but every person's different. But that's why it's important to start treatment early.
Okay, thank you very much. I believe that's all the questions and time we have. We are approaching the 1 hour mark. Thank you for all of the many questions, both publicly and private. I hope we managed to get through as many of them as possible. We are creating a Dr. Ahmed Shatila website where all this information will be posted, and any questions you can put on that website, which will be launched very, very soon. I will hand you back to Dr. Ahmed to give his closing comments, and then we will end the webinar after that. Dr. Ahmed, what are your final thoughts, please?
Thank you, Gerard, very much for the end or the conclusion. First of all, I'd like to thank everyone for attending today's webinar. I'd like to thank our sponsors. SSMC Sheikh Shakhbout Medical City, for allowing us to have this venue. I'd like to thank our sponsors, Lundbeck, for also making this possible. But finally, I'd like to thank everybody who attended. And, the thing is, I think the most important thing is recognizing symptoms, seeking help early on, because we can help people with dementia. Help is available, and that's what I think is the most important thing. Thank you very much.
Thank you very much. Good evening, good morning, wherever you are in the world. I hope you have the rest an enjoyable day, and we will now be ending this webinar. Thank you all.
Thank you. Ma salam, everyone.